Thank you, Vaughn, and what an exciting start to our entire convener today. I'm going to talk about an area that is a contrast, I think, to what we've heard. What we've heard from our first panelists is about constructing, about building. And now we'd like to turn to the question, how do institutional decisions perpetuate racism, perpetuate discrimination, perpetuate bias, and a lack of equity? And for this part of our discussion today, we're going to have a sort of wide open panel. So I invite anyone who is with us today to chime in on this particular area of discussion. I'd like to first maybe invite Rakia to talk a little bit about institutional decisions from a workforce diversity perspective.
Thank you. And I'm excited to talk about this. So I think one of the things that we don't consider as much is the ways that hospitals and healthcare facilities are microcosms of the greater community. And so when we think about equity, in terms of those institutions, we need to think about how they treat all of the people who work with them, particularly thinking about some of the low-wage workers and some of the independent contractors that work for them, and to ensure that they do not lack access to healthcare, health insurance, and can be healthy. When I was in Cleveland, we saw a few of the healthcare institutions really committed to this, including Metro Health, where they decided to pay for the health insurance of all their workers, especially the lower wage workers, to ensure that they also raise the minimum wage to $15, especially for, again, their low wage workers. And this is so key because we don't often take into consideration how these members are part of the community, that they oftentimes try to seek to get healthcare there. And that is a greater example to the larger community, how you treat your lesser workers. And I just highlight that it's not just, right, the people who clean, who serve food, but we often have to think about some of the traveling nurses who are a part of that. If these institutions have nursing homes or provide home and community-based care, that all of these people work within the healthcare structure and system, but often are at poverty level, can't afford insurance. And so that is another way to think about equity, that if we do not provide for these workers, then we are just perpetuating discrimination and unequal access to healthcare.
Great. Thank you for leading us off, Rakia. And what about inserting equity into decision-making across the continuum of care? I pick up on a little bit of what you said at the end there about, for example, in long-term care and a lot of facilities where much of the workforce is working at the very lowest end of the wage scale. And what we've seen during this period of COVID is that's the vector that's been most exposed to the disease, most exposed to the vagaries of employment and unemployment, and least protected. And so is that part of what you talk about when you say we really have to look at who is included in the community? And it is the people who work in the healthcare arena broadly.
Yes, and so I definitely throw it out to everybody else too, but I was able to write a paper around this, around nursing home care, particularly the disparities that we saw during COVID in terms of deaths, particularly in predominantly Black and Latino nursing homes. but then also connecting that with the workers, right? The fact that many of the workers were unprotected, didn't have PPEs, didn't have paid sick leave, weren't covered under many of the economic relief bills because they were exempted out, because there was a worry we wouldn't have enough people working in nursing homes and providing community-based care. And so we do not really hone in on this problem, and we don't keep track of the workers who have been impacted by COVID-19 in nursing homes and home and community-based care, even as we track the numbers of deaths of residents who were impacted. And so really ensuring that institutional decisions to move us towards equity include all the people within the healthcare system, including the workers, particularly the vulnerable who provide care to the most vulnerable in nursing homes and home-based care.
So how do we go about doing that? How do we go about inserting equity into decision-making across the continuum of care? We've heard in the first segment that a lot of this work has to start with leaders, start at the top, from Andres and others. And so if that is a given, how in the the institutional aspect of the healthcare system do we begin to move that needle? And I would invite anyone to chime in.
Yeah. Myra, I'll jump in here.
Sure.
Certainly, since you mentioned me here in terms of one of the comments that I made earlier, as I referenced in the first session, we have been, this has been a 10-year in the making, certainly journey for us. And we started, of course, with a diversity and inclusion journey that became really that foundation for us. And about 5.5 years ago, when I arrived here, is when we built the health equity, especially when we signed the 1, 2, 3 for Equity Pledge that actually has 4 key mandates, 4 key goals. One of them was actually around, collecting the data, right? The REL data that we call it, race, ethnicity, and language preference. But we didn't stop there. We actually ended up, collecting other data in terms of SOGI, sexual orientation, gender identity, also military veteran background of our patients, disability as well, because we understood that it was important, right, for us to really look at all the different dimensions of diversity. And so part of our journey has been looking at being very intentional and strategic, right? And looking through that equity first lens. And so part of what I will say here is that where you reside matters, right? Typically our function of EDI, equity, diversity, inclusion, tends to only reside or report into HR. And the issue with that is that then you become just a human capitalist by nature of that. What I love about Freighter is that actually I reside under the EVP COO of our system. So that allows me to sit around the same table with all the other chief officers and really have really great discussions around the work that we are driving collectively, right, as an organization. And then really helping and advising and also mentoring all of my leaders so they can start developing their own EDI right lens and or exercise those muscles so then they understand what's within my purview, how do I bake it in, and then how do we drive that, right? Ultimately, it really has to be woven into the fabric of the organization, into all the goals that you're driving, and then having very clear metrics. Because if you don't do that, then you won't know whether you're achieving the collective impact. And then ultimately then having, as I mentioned, the last piece for us was about 1.5 years ago when we decided to go one step further and then tie compensation into all of our goals. Because certainly then this also now hits the pocketbooks, right, of everyone in the organization, and it creates one more level of accountability for all of our leaders. And so that's the way in which we have been able to weave it into all of our goals. It's actually part of the overall strategy. So there's no goal within Freighter and the Medical College that we have not thought through from an EDI perspective, and we have baked those elements into those goals. And I think that that becomes paramount if you are certainly, again, committed and you're going to be driving a true equity, diversity, inclusion, and anti-racism strategy.
I'm wondering if we can hear from Harold because I saw your comment in the chat, and you've got an interesting perspective also to bring in here.
Yeah, I put a link in the chat to an op-ed my colleague Amal Navatha and I wrote in the Times last year, where we looked at payment models. So as we just heard, there's a lot of potential for hospital systems within their own cultures to turn things around, but in many ways, they also need to respond to the incentive structures that are established around them. And so in many ways, we see good initiatives that try to reward not just piece rate, doing a lot of things, but try to reward value and focus on outcomes. But some of these proposals can have unintended consequences in that you don't want to have a payment model that rewards you if you have low readmissions or achieve particularly good outcomes, if that then leads to shunning more complicated patients who, because of the consequences of structural racism, are more likely to be minorities. And yet we've seen that, and the link that I've sent you documents several studies that illustrates this. We've seen that happening. So what we suggested in our piece is, one, that we need to have a good sense of what's actually going on, because we don't. This is another one of those aspects where we don't deal with structural racism, where somebody just says, well, you're Black, I don't like you. That's a sort of dumb version of racism that I think is not very interesting, as appalling as it is. But we're dealing here with another form of basically unintended consequences, if you want to call it that, to not offend anybody. But I think in many ways, it raises all the same issues, that we need to understand what is going on. We need an actual review, a systematic review of those kinds of policies and systems that enable us to have warning flags go up if it turns out that some of these models do have the consequences that more disadvantaged populations are shortchanged in the pursuit of efficient delivery of healthcare. So I think that's something where, whether legally you call it disparate impact monitoring or process evaluation in more health service research oriented terms, but something where we want to make sure that a major initiative that is underway that directs payments in ways that rewards good outcomes doesn't lead to more disadvantaged communities and by implication more minority populations to be shortchanged in the process. So I think that's another key part we really need to pay attention to.
Thank you, Harold. And I'm going to give a brief introduction, because you have not been previously introduced to our panelists. So Harold Schmidt is an assistant professor at the Department of Medical Ethics and Health Policy, research associate, Center for Health Incentives and Behavioral Economics at the Perelman School of Medicine, University of Pennsylvania. Dr. Schmidt's research interests are centered around improving opportunity and reducing disadvantage for marginalized populations in health promotion and healthcare priority setting. So
that's all correct. And I'm really glad to be here, because one of the things I really regretted not having studied is law. So I'm very honored to be with many of you, since I've learned a lot from reading your work. But here I get to talk to the real lawyers, so I'm very pleased about that.
Yeah, and I would invite Vaughn to jump in here, because she's added some comments in the chat as well. Vaughn?
Thanks, Myra. For me, it's just about us asking different kinds of questions. We've been operating in a very specific paradigm in this industry for so long that I think we've forgotten how to imagine and think creatively. And so we need to bring that back. What is the equity impact should be a part of that conversation, but we have to intentionally insert that question. It's not currently built into the way we think about our problem solving, right? We have to intentionally insert the idea of if our value that we are adding is that we are eliminating disparities and that we are reducing inequity in our system, then we have to build those kinds of questions and conversations into our process for how we plan. But right now, there's not really a lot of mechanism for doing that, because, as Harold said, the payment models haven't caught up to that yet. And a lot of the strategic that's taught in health policy school and in business school doesn't focus on any of that. So I think we just have to start asking some different kinds of questions and be willing to go there.
Yeah, and doesn't that require, won't that require a sea change in terms of the, because as we all know, the payment system right now is designed around a lot of different incentives, all labeled paying for outcomes, that our payment system right now has moved from paying for procedures to paying for what is done to a patient, for example, to now paying for outcomes. And so how does equity and health justice play into that, if at all, or does it require an entire system redesign?
I mean, for me, I think we have to talk about what we mean by outcomes. I think right now we have a very narrow definition of outcome in terms of what is the result of the procedure. So instead of paying for the procedure, we pay for the result of the procedure. But the outcome in terms of someone's whole health is much broader than the outcome of an individual procedure. So I think that, from a policy perspective, we get to have a very different conversation about what do we mean by outcomes? What are we even measuring? And I think that's again, it's about thinking a little bit more broadly instead of reacting to the way the current system doesn't work. Let's imagine something a little bit different, imagine something new, not throwing everything away, but let's get out of the paradigm of, well, we put Band-Aids on this. And so, well, instead of paying for the Band-Aid, let's pay for the scab that forms 6 weeks after the Band-Aid. Okay, well, we're still focused on the Band-Aid. Let's talk about what it means for them to not get cut in the first place.
I would just second that. I would just second that. I think as was mentioned in the chat too, right? We want to talk about what value here is. So I don't think the problem is a conceptual one with focusing on outcomes. As you've just said, the question is, well, what are the outcomes? If it's reductions in access to healthcare across groups defined by a meaningful notion of social vulnerability, that is an outcome you can measure in very concrete ways and can be integrated. So I really think it's a matter of aligning this process that's underway and making it more focused, more attuned to avoiding inequitable outcomes. And I think the paradigm itself doesn't stand in the way. It's just that we need to be intentional about it and have attention to detail, really.
So going back to our overarching topic for this particular session, are there ways in which institutional decisions perpetuate racism, bias, and lack of equity in healthcare? I mean, we're all talking about sort of on the how to fix it, how to improve it, how to change way. But what are some examples of decisions and decision making other than those that we heard from Rakia with respect to workforce? Are there other decisions in the healthcare equations that perpetuate racism, that perpetuate bias? With respect to the delivery of care, Melanie?
So I'm going to answer, I'm going to be a typical lawyer. I'm going to answer your question, but maybe not answer fully the call of the question, because there was another point I wanted to make that's tied to that. I represent a different part of, I think, an important player in the continuum of care, and that's the pharma industry. And I think one of the ways in which we have acknowledged as a company that we had been playing into the racial bias is that historically for our clinical trials, we were going to the same players time and time again because we had relationships with those individuals, with those institutions, and we did not have a broad reach into communities of color where, in order for us to truly meet our ambitious goal of, delivering healthcare options for all patients, then we have to study healthcare in all patients. And we weren't doing that because we were going to a very narrow segment of, the healthcare population. And so I think that was one way we were inserting bias in a way, is because we didn't really know how effective some of our drugs for breast cancer, for example, were efficacious in Black women, which we know the disproportionate number of Black women, die due to breast cancer. And so one of the ways in which we course corrected, and I'm so excited to hear some of the speakers talk today, was around being vulnerable as a company to realize we don't have all the answers. And so we started to engage with community leaders across the United States who are addressing, how to advance inclusive research and how to address the biases in research. and also tapping into the local communities to understand how do we increase participation by Black and Latinx patients? How do we engage with physicians in these communities? And if there is a knowledge gap in terms of how to participate in clinical research, then how do we help close that knowledge gap? And so really moving from a paternalistic point of view to a more, I'll say still some paternalism there, we have a ways to go, but we are working on that to a more leaning in with curiosity and learning from the communities themselves in terms of how do we better reach, how do we expand our scope, and then also in creating new KPIs for our clinical trial teams. You know, they were incentivized by going fast. And then now we're saying, how inclusive are your clinical trials? How inclusive are our protocols? Are our protocols automatically designed to exclude certain ethnic groups because we might automatically, have higher, percentages of different things that might be part of the exclusion criteria, and really trying to take a whole multidisciplinary approach to increasing inclusion in our clinical trials. So from, the incentives internally as well as the outreach externally. So I just wanted to add that perspective, because I think the pharma med device industries are important players in increasing, increasing equity in the continuum of care. So.
And Melanie, if we could stay with you for just a minute, I'd like to ask if and thank you for contributing your company's process in self-examination, I think is what was required. But what about the rest of your industry? Is this also a dawning happening across the pharma industry?
It is. I think it's slowly but surely happening. I think more and more companies realize that, it's an imperative, and that as an industry that we definitely have to address our practices. So, you start to see more, there's a trade association called Pharma, and they've brought different members of industry together to talk about what is our stance on inclusive research? How do we address health equity, not just in our research practices, but also in our other business practices? So that's another area where you're starting to see others in the pharma industry and med device industry come together. I think COVID also highlighted why it's imperative for us as an industry. But I think we have such a long way to go, right? I think this is the first step in the right direction. Our CEO and other CEOs are starting to make very vocal, active commitments, and not just talking the talk, but walking the walk, to really increase the impact that we can have in addressing equity in the healthcare field.
Thank you. I really appreciate that. Thank you, Melanie. And Ed, you've got an active and quite connected and long set of questions in the chat. So I'm going to invite you to come forward and share.
Yes. Well, thank you. I've been
Sure.
appreciating this conversation. I was a state health officer for 7 years and really looked at all of the social issues, and we, in trying to build in equity in everything we did, we set up a theory of change about around community organizing the narrative, organizing the resources, and organizing the people. And we decided in each of those areas, we had to ask specific questions on every single policy and every decision that we made. And so what I put in the chats were the questions that we asked with every policy decision, every programmatic decision that was made. Who's benefiting? Who is left out? What worldview do you bring? Do you bring that whole worldview of an individual responsibility, or community perspective? Do you bring it from a white perspective or a more diverse and inclusive perspective? And so those were the questions that we put, and it really actually changed how we did our work at the State Health Department, and it is having impact throughout our state in Minnesota.
Great, thank you. And again, in the chat, I believe, critically important suggestion by Vaughn about the fact that maybe we think about changing medical education. Do you want to talk a little bit more about that?
Yeah, this is something, because I did a lot of work when I was in practice with GME, I got to see what the criteria were for professional competence, and they never thought about or talked about equity and sort of what it means to treat patients from an equity perspective. And the more I look into this and the more I do research around it, you think about how are we even taught what constitutes professional practice? How are students, med students taught, how to engage with patients and how to interact with communities? And to a great degree, they aren't taught that, right? There's a bias and sort of a racist perspective built into a lot of the curriculum that has never been challenged, right? And we're at a point now where I think we need to challenge those things, because I cannot expect someone to do better if we haven't taught them any better. And so when we think about what are some of the ways that we as institutions, if we are running training programs, if we are, delivering medical education, have those equity questions that Ed put in here. Are those a part of the way we design our instruction and our curriculum? Have we even considered how those things impact? And if we haven't, we really need to get on that if we want to have the kinds of significant impact on shifting the way healthcare is done.
Great. Cindy, do you have a hand up? I'm seeing your hand up. Is that for time?
No, not for time.
Okay.
I had a question that I wanted to ask Melanie and others. We've all heard and seen, the historical hesitancy and concern that many diverse communities share because of, sadly, horrifying things that were done to them in the past. We all know about what happened at the Tuskegee Institute. So how would you all suggest ways to break through that concern and that hesitancy and help those communities recognize that, not in a paternalistic manner, because I think that's probably the worst thing we can do, to say, oh, don't worry, everything's fine, we're treating everybody well now, but how do you really break through that and try to get the diverse community to recognize it is okay to participate in a clinical trial? I will be treated just like everyone else who's participating in it. I actually have a client that's got a multi-site, clinical trial organization that was very involved in the COVID vaccine trials, and was working hard to try to bring in more of the diverse community into their database of patients. Because as you said, Melanie, they kept going back to the same places all the time, and they want to try to expand that. Thank you.
I'll start, but I don't know that we have the perfect solution. I think it's about, we're operating at a significant deficit of trust still to this day. I think, from participating in clinical trials all the way just the relationships that they have with their healthcare providers in and of itself. It kind of goes back to the point Vaughn was raising, that there is still this bias that healthcare providers have, and it impacts their relationships with their patients. And then the removal of institutions from communities so that they no longer are able to build relationships with their providers. They only have these urgent care centers, or, now they're only seeing doctors through the ER. Like, that's just completely eroded, the old concept of having a relationship with your family physician. That being said, I think one of the ways that we are trying to overcome this hurdle is by the relationships that we're building with community leaders. So it's kind of one leader at a time, one community at a time, and trying to establish that trust, and talking more about the benefits and the value of diverse participation in our clinical research, and leveraging those thought leaders and those who know the community and know what will go well. I guess what information the communities will receive better is the best way we found to be effective and impactful. And then by storytelling, by having people who've participated in those clinical trials and their positive experiences on those journeys, I think has also been impactful for us as an organization. But I think those are just, continuing to engage. I cannot emphasize how much we have come to learn and really value the importance of community engagement at all different levels. And it's one relationship built at a time.
I would like to add to that because, when the pandemic started, certain agencies, we were meeting NIH and all these folks, and they're like, what do we do? How do we, how do we get people enrolled in trials? And I was, they're looking at the Native and Black community, and we're like, we ain't got nothing for you here. And, and they're like, but we need the data. We need it now. We need to figure out how the vaccine. Okay. But what they say, kind of, what I said was like, it's too late. If you're trying to build a relationship right now during a pandemic, it's too late. You should have built these relationships a long time ago. And so, yeah, it is going to be too late. And if they do want to have better trials, it does take a true systemic commitment, I believe, to really engage the community. Because, I mean, I grew up in the Black community. I represent the Native community. Both of those communities are telling me, I don't care what you're saying, Francis, I'm not taking the vaccine. And so I think a lot of it has to do with trust and building it over time, and not just when, they wanted trials. Because I think that's, for my community anyway, that's how it looks like. Oh, now you want me engaged in trials? Yeah, I'm not going to take that. And Tuskegee came up a lot for that. And they used to, sterilize Native women in IHS. In the IHS system, the same system that we're working in today, is how they were sterilized. So some community is like, some folks are like, no, I'm not doing anything with the trial, and I think that's going to take, I think, a lot of time to dismantle the lack of trust that our communities, rightly so, have with these systems. So I think, yeah, community engagement is key. And it's still, even with that, it's going to be hard, I think.
Well, thank you, Francis. And on that note, we are getting close to our time, and I think we're about a minute out. So I would ask if anyone has a last comment for this very interesting session. Great. Well, with that, I will turn it over and I'll turn it back to Cindy and the next person.